Welcome to Derm Drop, your TLDR in dermatology. I'm David Sider, your host, bringing you quick picks from the dermatology literature and other sources in the dermatology community that are interesting and impactful. Episode 9 begins with an article on ophthalmic vitiligo. Do you need to keep an eye out for it? Well, if ocular melanocytes can succumb to melanoma, what happens when they are affected by vitiligo? When melanocytes in the ear are affected, which occurs in almost 40% of patients, it results in sensorineural hearing loss because melanocytes regulate ion channels in the cochlea required for hair cells to translate sound into neural signals. Luckily, most of that hearing loss occurs at higher frequencies and is subclinical, but not all of it. So, can vitiligo affect other senses too? Prior research has reported associations between vitiligo and retinal issues, such as detachment and pigment abnormalities. Fortunately, retinal melanocytes do not directly affect visual processing, acuity, or field perception. But the authors of Auditory and Ocular Manifestations in Pediatric Vitiligo noted that sensory abnormalities in pediatric vitiligo remained unexplored despite PEDS patients comprising over 50% of vitiligo cases. So they conducted a retrospective cohort study of 21,833 vitiligo patients less than 18 years old and an equal number of matched controls presenting to 89 U.S. healthcare organizations from 2016 to 2024. Their findings, published 11 June 2025 in JAMA Dermatology, included elevated risk of retinal and choroidal disorders, including chorioretinal inflammation and degeneration, retinal detachments and breaks, etc., among the vitiligo patients. Hazard ratio 1.56. But the significance was lost in sensitivity and time stratified analyses. And there were no significant differences in vision impairment, uveitis, glaucoma, or dry eye disease. So it doesn't look like ocular complications are a significant concern in your typical vitiligo kid. But when should you be on the lookout? First, be aware that periocular cutaneous vitiligo increases the risk of intraocular involvement at any age, and rates of ophthalmic complications are higher in adults. The most common of these is xerosis, which affects up to 20 to 40% of adults with vitiligo. But as annoying as dry eye can be, not all ocular complications are that benign, as rates of uveitis are higher in this population. Of course, symptoms of uveitis, for example, pain, erythema, photophobia, blurred vision, and/or floaters, require referral and may be indications of an associated autoimmune condition such as VOT, Koyanagi, Harada, or VKH syndrome, requiring ophthalmologic co-management. So don't forget about the eyes in vitiligo. Our next article is about anogenital strep and psoriasis. Dermatology clinicians already know that strep throat can trigger guttate psoriasis, but did you know that anogenital strep and staph may drive pediatric inverse psoriasis? Well, the association between anogenital bacteria and neighboring psoriasis was illuminated in a multicenter retrospective review published 12 June 2025 in Pediatric Dermatology, which looked at patients less than or equal to 18 years of age who had psoriasis or psoriasiform dermatitis and positive streptococcus or staphylococcus cultures between 2011 and 2021. As you know, psoriasis results from a complex interplay between genetic and environmental factors, and one of those factors is infection with streptococci, which express proteins that activate T cells, especially Th17 cells. The problem is keratin proteins look similar to strep proteins, so activated T cells think they're part of the infection and escalate the inflammatory response in the epidermis. So that's the classic strep throat to guttate psoriasis pathway. In the anogenital infection to inverse psoriasis pathway identified in this study, 53% of the cultures grew Staph aureus, while 41% grew strep species. Like strep, staph expresses proteins with structural or functional resemblance to keratins. So, voila, another case of mistaken identity resulting in unnecessary inflammation in uninfected skin. So, when a pediatric patient presents with inverse psoriasis, what should you look for? The patients in the study with anogenital infections had erythema, 78%, pruritus, 25%, fissures, 12%, and pain, 8%. However, 5% of patients with positive anogenital and 27% of those with positive pharyngeal cultures were asymptomatic, indicating chronic colonization rather than overt infection or intestinal dysbiosis, which can also activate T cells. The kiddos with suspected anogenital infections were treated with systemic antibiotics, 77%, and or topical antibiotics, 40%. Interestingly, the authors did not find a significant correlation between treatment of the underlying bacterial presence and psoriasis or psoriasiform dermatitis outcomes, though this has been seen elsewhere. Nonetheless, they recommend maintaining a high clinical suspicion for microbial involvement in pediatric cases of new onset or worsening psoriasis, especially the inverse and guttate phenotypes, and considering physical examination or in other investigations such as swabs and or serologies even without symptoms of infection. Thanks to the authors of this study for exploring this connection and to the Pediatric Dermatology Research Alliance, or PEDRA, for funding it. Our next article in episode 9 is actually a communication from the U.S. Food and Drug Administration on antihistamine withdrawal. Is that even a thing? Well, on May 16th, 2025, the FDA issued a drug safety communication regarding the risk of severe itch in patients who stop cetirizine, marketed as Zyrtec in the US, or levocetirizine, aka Xyzal, after long-term use. Dermatology clinicians who prescribe these medications for pruritic conditions like urticaria may be tempted to roll their eyes and mumble to themselves that, of course, the itch will recur when treatment is discontinued. But this is widespread pruritus that the patients did not have prior to using the medication. It's kind of like topical steroid withdrawal in that the symptoms are not just a flare of the underlying condition. Many patients described a significant impact on their quality of life and ability to function, and some required medical intervention. The FDA identified 209 cases reported between 2017 and 2023. The total number of patients who stopped these drugs after long-term use during the same period is not known, so we can't calculate the incidence rate. But given the prevalence of these products, it's probably safe to say it's a rare but underreported phenomenon. In fact, many consumers have come forward with their own anecdotal reports since the announcement was made a few weeks ago, describing weeks to months of quote unquote miserable itch. The underlying mechanism is unknown, but most patients who experienced withdrawal pruritus were on the medication for more than 3 months, though some after less than a month of use. The itch typically started within a few days of discontinuation, and for most it resolved after restarting, and for some it resolved after tapering off. The FDA is revising the prescribing information to include a new warning about this risk for prescription cetirizine and levocetirizine, and they will request that manufacturers add a warning to the drug facts label for OTC versions. So, what should derms do? Well, ideally, prescribe another second generation H1 antihistamine, such as fexofenadine or loratadine instead. Or if cetirizine provides better control at 4x dosing, you could rotate it in for flares. Some clinicians rotate antihistamines due to widespread belief in downregulation of histamine receptors, resulting in tachyphylaxis over time. Patients may also believe they have developed a quote unquote tolerance or become quote unquote resistant to their favorite allergy pill. However, there is no compelling evidence to support this practice at this time, as waning efficacy may be due to seasonal variation in exposures or waxing severity of histamine driven disease over the lifespan. In fact, studies have shown unchanged efficacy for up to 180 days of continuous use. But rotation may be a valid strategy for those that want to keep cetirizine or levocetirizine in their treatment algorithm for preemptive seasonal or situational regimens when dose escalation is already maxed out and control is suboptimal. Our last article of episode 9 is about simvastatin for vitiligo. Yes, the cholesterol lowering drug is an effective adjunct in vitiligo treatment, first explored over 10 years ago by Agarwal et al., who noted that the classic statin is, in fact, a STAT1 inhibitor which blocks interferon gamma, the primary cytokine implicated in vitiligo, and successfully tested their hypothesis in a mouse model. So it's not exactly new, but it has recently been validated by Saudi, Egyptian, and Chinese researchers who performed a meta analysis of six randomized controlled trials with a total of 371 participants meeting eligibility criteria. And what did they find? They found that the odds of achieving 75% repigmentation were almost 7 times higher in the simvastatin group compared to controls or in pre and post treatment assessments. A previous study published in 2024 by Niezgoda et al. Looked at topical simvastatin and atorvastatin, which did not result in significant repigmentation or improved VASI, or vitiligo area scoring index scores, but did inhibit disease progression more frequently. Of course, in addition to much better results, systemic administration provides a two-for opportunity with cardiovascular disease risk reduction as well. So, where does an oral adjunct fit in, especially with JAK inhibitors poised to get vitiligo indications next year? When JAK inhibitors are inaccessible or contraindicated, obviously. So, if you're treating with old school topicals and scheduling narrowband UVB or solar phototherapy, why don't you throw in some simvastatin too and turbo boost your results? And if you don't feel comfortable managing a statin, collab with the PCP. It could be as simple as scribbling a note to them for them to take to their follow up. Vitiligo is hard to treat, so I wouldn't leave anything on the table. And while you're at it, offer Dr. Amar Ahmed's ACE antioxidant cocktail consisting of alpha lipoic acid, vitamin C, and vitamin E, hence ACE, which he shared on episode 168 of Dr. Raja Sivamani and Dr. Hadar Levtov's Integrative Dermatology podcast, Learn Skin. Antioxidants do reduce melanocyte stress, which may lie at the root of the autoimmune response, and they do have data to support their efficacy. And patients, quite frankly, love the complementary touch. And that's it for episode 9 of Derm Drop. Thank you for tuning in. This episode was written and hosted by myself, David Sider, with production and distribution help by Jacob Gary. Welcome, Jacob, to the team. We're happy to have you. And if you're interested in links to the articles discussed in this episode, they are available on my LinkedIn page, which you can find at linkedin.com/n/Dave Seiter. That's Seiter. And if you liked the episode, hit that thumbs up button, share it with your colleagues, and be sure to tune in 2 weeks for our next episode. Thanks.